I work in epidemiology and in public health, so it's really promoting comprehensive hepatitis prevention and treatment programs throughout the world. WHO is updating its hepatitis C screening, care, and treatment guidelines. We issued them first in 2014, exactly 2 years ago at this conference, and they covered recommendations on who should be tested, how you assess for fibrosis, and what treatment regimens should be used. A lot has happened in those 2 years, specifically with the development of the new treatments for hepatitis C. Several new direct-acting antivirals have been approved, and they've really transformed the treatment landscape for hepatitis C. So we wanted to be sure to be able to provide program managers and clinicians advice on how these new medicines should be used. What we've done is reviewed the evidence about the safety and the efficacy of the new DAAs, as they're called, and have come up with 3 broad recommendations that are new. The first is more of a policy kind of recommendation, is that countries should move towards using all oral regimens. In many countries, interferon is still being used because it's less expensive or it's more easily available. But we really want to move countries to using these drugs that we know are safer, more effective, and also in many countries now cheaper because of generics. So that's the first recommendation. The second recommendation was to no longer use telaprevir and boceprevir, which were the first generation protease inhibitors that were part of our 2014 guidelines. We now know that there's better medicines that should be used. So we reviewed the evidence and decided that those should no longer be used. So we're recommending against the use of those 2 drugs. Most importantly, for the first time, we're issuing preferred regimens. So we, by genotype, 1 through 6, and by cirrhosis, whether a patient has cirrhosis or not, we've come up with regimens that we would call preferred regimens, which means this is the ones we really think are the best option for patients. We also have alternative regimens, which can also be used, but they're perhaps more difficult to take or have more drug-drug interactions. So we feel that they're not as they're not as good as the preferred regimens. In the guidelines, we have a table indicating which which combination of DAA should be used by genotype and by cirrhosis status. So we hope will move countries. WHO guidelines are meant for the whole world, but in reality, we know that the European countries have the EASL recommendations and American has the American recommendations. So ours are really targeted more at low and middle income countries. And we hope that this guidance will move countries to introducing those medicines, getting them registered, procuring them, and using them in the countries. At this conference already we're hearing continued progress. Many countries are taking on hepatitis in a major way. Georgia is perhaps, the country Georgia is the most dramatic example that they've decided to eliminate hepatitis C in the next 5 years. Other countries, Mongolia, Egypt, Pakistan, are really scaling up. So we hope that these regimens, which cure more than 90% of people, are safe, easy to take, will facilitate that scale up. So in addition, we also have the recommendations that we are reissuing our existing recommendations, talking about who should be tested, basically groups that are part of populations at higher risk of getting infected should be tested. The infection should be confirmed with a nucleic acid test. And we also say that to assess fibrosis and cirrhosis, which is still an important step in deciding who should be treated, we recommend this APRI, which is a simple test using laboratory measures that are available everywhere. Hepatitis C and B are both major causes of global mortality and morbidity. There's an estimate that viral hepatitis is the 7th leading cause of death worldwide, of all causes. So clearly it's a major problem. Now, in the last few years, with these dramatic improvements in the medicines, we have great medicines for C and for hepatitis B. The problem is that people are not being treated. So we have a big problem. We have a solution, these medicines, but we really have to make doctors more aware of the problem, make patients more aware, so that patients are tested, and if they're found to have hepatitis B or hepatitis C, that they're referred for assessed for treatment and are started on treatment. We know that if you're cured of hepatitis C, or if your hepatitis B is controlled with the medicines, your chance of getting cirrhosis, your chance of dying from cancer or cirrhosis is reduced dramatically. So it has a major impact.